Thousands of COPD patients in the UK are using oxygen therapy right now, and it is making their condition worse, not better. But here is something even more important you need to understand. An equal number of patients who genuinely need oxygen aren't receiving it, and both of those situations are life-threatening. Here is what you actually need to know about one of the most misunderstood treatment in all of respiratory medicine. I am Dr. Suman Paul, consultant respiratory physician in the UK. In last 15 years of treating COPD patients, what I'm about to show you is something most doctors simply don't have time to explain clearly enough. This is education, not personal medical advice. Struggling to breathe at rest? Call 999 or see your doctor. Here is what you actually need to know. Oxygen is not a comfort drug. It is a survival drug, and it's not what most people think. Most people assume oxygen is prescribed for breathlessness. That if you feel short of breath, you need more oxygen. That logic makes complete sense on the surface, but it is wrong. When COPD reaches a certain severity, your lungs stop loading enough oxygen into your blood. Not just a little, dangerously low levels. Day after day, year after year, and silently without you always feeling it. Your heart, your brain, and your kidneys begin to suffer. That is what we call chronic hypoxemia, chronically low blood oxygen levels. That is what long-term oxygen therapy treats, not how breathless you feel. The actual oxygen pressure dissolved in your blood. Now, I know what many of you are thinking, but Dr. Paul, when I breathe extra oxygen, I do feel better, less breathless. And I believe you, that feeling is real. But, and this is critical, that sensation of relief is not proof that your blood oxygen was dangerously low. Sometimes it's cool airflow across your face stimulating your nerve receptors. Sometimes is psychological reassurance. And sometimes, in the wrong patient, that feeling of comfort is masking something dangerous happening quietly underneath. Therefore, we cannot rely on how you feel. We need to measure exactly what is happening in your blood. But there is something even more important you need to understand, because the criteria for who actually qualifies for oxygen on the NHS, it's not what most people expect. And if you have ever been told your oxygen levels are fine, you need to stay with me for this next part. Here is what you actually need to know about NHS oxygen. We use NICE guidelines to determine who receives long-term oxygen therapy, what we call LTOT, and the criteria are very specific. It is not about how breathless you feel, it is about a number in your blood. We measure something called an arterial blood gas and ABG, not the little clip on your finger. That SpO2 finger reading is useful for screening, but it is nowhere near accurate enough to prescribe a drug this powerful. We need the actual pressure of oxygen dissolved in your blood, your PaO2. The threshold for LTOT is PaO2 below 7.3 kilopascals. In plain terms, your blood oxygen pressure is chronically, dangerously low, and your body is quietly being starved of oxygen even while you are sitting completely still. But there are two rules most people don't know. Rule number one is we test that number twice, at least 3 weeks apart. Because if you have just had a flare up or a chest infection, your oxygen will be temporarily low. And basing a lifelong prescription on a single bad reading means we may be giving you a drug you don't actually need. Rule number two is you must be clinically stable when we test, not mid-flare, not still recovering from hospital. Stable, that is when we get the true picture. There is a secondary category too. If your PaO2 sits between 7.3 and 8, you may still qualify, but only when specific complications sits alongside it. Polycythaemia, where the blood becomes too thick, pulmonary hypertension, raised pressure in the lung blood vessels, or swollen ankles from right-sided heart strain. The bottom line, the question of whether you need oxygen cannot be answered by how you feel. It can only be answered by a proper blood gas measurement done at the right time by a respiratory specialist or oxygen team. Here is the game-changing part most people miss, because there is a trend happening right now and I am genuinely worried about it. I am seeing more and more patients fall into a trap the internet has made very easy to fall into, and it can cost people their lives. Oxygen concentrators are now listed on Amazon, eBay, health and wellness websites, delivered to your door for a few £100, next day shipping. And I understand exactly why people buy them. You are breathless, you are frightened, You have been waiting months for an NHS appointment. You just want help now. But here is what the product listing doesn't tell you. Oxygen is a drug. In the UK, it is a prescribed medication, regulated for very good reason, and giving yourself unmonitored, unassessed oxygen when you have COPD can trigger two things that can kill you. The first is CO2 retention. Many patients with severe COPD already have elevated carbon dioxide level in their blood. Their system has adapted to this over years. But when you add extra oxygen without specialist oversight, something called the Halden effect kicks in. Oxygenated hemoglobin releases carbon dioxide into the blood faster than your damaged lungs can clear it. At the same time, extra oxygen disrupts the body's natural blood flow away from the damaged lung regions, and your CO2 climbs even further. Think of your lungs like an old patched ventilation system, compensating, running on a very specific pressure balance it took years to establish. When you flood that system with oxygen without checking the valves, it backs up. The result is CO2 narcosis, drowsiness, confusion, unconsciousness, sometimes even death. The second one is fire. Oxygen doesn't burn, but it accelerates fire with terrifying speed. The NHS mandates a full home safety assessment before fitting any patient with oxygen at home, because even a scented candle, a gas hob, or a faulty e-cigarette battery near a concentrator can start a fire that engulfs a room in seconds. When you order online, none of that assessment happens. But there is something even more important you need to understand, because I am not just here to warn you about danger. There are patients right now, some of you watching this, who genuinely need oxygen and are not receiving it. And that has its own devastating consequences. Here is what you actually need to know about the other side of this. The LOTT or LOT trial, one of the largest clinical trials ever run on oxygen therapy for COPD, showed us something important. Oxygen does not improve survival in patients with moderate COPD and only borderline or exercise-related oxygen drops. But for patients with a true PaO2 below 7.3 kPa, the evidence is definitive. Long-term oxygen therapy used correctly improves survival. It reduces the strain on the right side of your heart. It slows the development of pulmonary hypertension. It protects your organ. The critical word is correctly. That means a minimum of 15 hours a day, not 2 hours when you feel breathless, not just overnight, 15 hours, including rest, sleep, and activity throughout the day. Below 15 hours, the survival benefit disappears. Now, here is what genuinely concerns me. Nice quality standards are clear. Any patient with a resting SpO2 of 92% or below should have arterial blood gas measurement. Not just a finger clip reading, a proper ABG, sometimes a capillary blood gas. But I see patients regularly told their oxygen is fine on the basis of a finger reading of 92%. Their GP is doing their absolute best in a 10-minute appointment, but 92% or below warrants further assessment, a proper specialist review, actual blood gas measurements. If that is you or someone you love, please request your GP for a referral to respiratory medicine clinic. Remember this, because these three myths, I hear them every single week and they are causing real harm. Myth number 1, oxygen will make me dependent on it. No, oxygen is not addictive. If your need increases over time, that is COPD progressing, not the oxygen causing dependency. Do not let this fear stop you from getting properly assessed. Myth number 2, I should use my oxygen when I feel breathless. If you are on LTOT, you use it consistently for 15 plus hours every day, not as a rescue inhaler when symptoms worsen. Sudden worsening breathlessness means a flare-up that needs your doctor, or in severe cases A&E. Oxygen alone will not manage an exacerbation. Myth number 3, higher oxygen levels are always better. Absolutely not. If you have COPD, your target saturation is often 88 to 92%, not 99%. Pushing above 92% in the wrong patient is exactly how you trigger the CO2 retention I just described. Correct is better than high. So what do you actually do with all of this? So if you are currently on home oxygen, check you are genuinely reaching 15 hours every day. That is the minimum threshold for clinical benefit. Falling short, speak to your doctor about how to increase your hours safely. If you are breathless but not on oxygen, do not buy a machine online. Ask your doctor for a referral to a respiratory specialist or oxygen clinic in your area. Done when you are clinically stable. That is the only way to know whether you actually need it. If you have been told your levels are fine, but something doesn't feel right, request a specialist assessment. A resting SpO2 at or below 92% warrants blood gas assessment under the NICE guidelines. You are entitled to ask for that. If you are on oxygen and want to travel within the UK, contact your regional oxygen supplier. They can arrange equipment at your destination with enough notice. For flights abroad, ask your respiratory consultant about a hypoxic challenge test before you book anything. It's not readily available in all hospitals, but it can be available privately. I had a patient who spent £500 on an oxygen concentrator he found online. He was using it every single day. Breathless, frightened, couldn't get seen quickly enough through normal channels. We stopped the machine. We ran proper arterial blood gas measurement when he was clinically stable. His PO2 was 8.2 kilopascal. He did not meet the clinical criteria for long-term oxygen therapy. What he actually needed was his inhaler technique corrected, a proper pulmonary rehab program. He is now walking 30 minutes every single day. Not been admitted to hospital once in last 12 months, his quality of life is completely transformed without any home oxygen at all. But here is the other side of that story. When used correctly for the right patient, in the right dose, for the right number of hours, long-term oxygen therapy can add years to your life. It protects your heart. It protects your organs. That isn't just a statistics. That's peace of mind. And it starts with one question, not can I buy oxygen online, but do I actually need it? And has anyone properly measured that? That is exactly what I help patients work through every day at my private respiratory clinic here in Liverpool. If you are exhausted by breathlessness, confused about your treatment, or you have simply never had a proper specialist review, I would genuinely like to help. The link to book with me is in the description box below. If this gave you clarity, please share it with someone who has COPD and is thinking about oxygen. It might be the most useful thing they see today. I'll see you in the next video.